Thank you. First of all, I would like to thank the organizer for giving us opportunity for the presentation. Today, I would like to share our initial findings of our modeling study. But please know that our study is work in progress. And in that sense, I would appreciate the feedback from you, the audience. Vietnam is a country in Southeast Asia with a population of about 87 million. HIV prevalence in general population is at 0.45%, but HIV prevalence in IDU, injection drug users, is at 13%, suggesting Vietnam has a typical concentrated epidemic, most notably driven by injection drug use. In response, Vietnam introduced and expanded harm reduction interventions, and also making efforts to maximize preventive and survival benefits of antiretroviral therapy, or ART, through piloting Treatment 2.0 and also implementation study of treatment as a prevention. Therefore, objective of our modeling study was to identify optimal targets and strategies for future HIV control interventions that include early ART. We used available surveillance data from Kanto province in southern Vietnam, which has a population of about 600,000. We assumed if people initiate ART, both sexual transmission and needle-sharing transmission will be reduced by 96%. As for cost, ART, we assumed US $379 per person years based on actual costing study in Vietnam, HIV test at $3.5 per test. After we establish a model to that match Kanto's epidemic, we examined the impact of impact of interventions. That is to regularly offer HIV testing, followed by immediate ART if tested positive, regardless of CD4. We assumed we maintain current level of other HIV prevention interventions. We created 7 subpopulations in our model. IDU stands for injection drug users. For MSM and female sex workers, we created 2 groups, one with drug injecting behavior and one without. By the way, do I have a razor pointer? Thank you. So two groups. MCF stands for male clients, and LRW stands for low-risk women. Red arrow shows needle-sharing transmission, blue arrow sexual transmission. Group colored pink color is a group where ongoing HIV transmission is happening within the group. Let's move on to the results. Left graph shows cumulative HIV new infection in 2010 to 2050. Vertical axis shows testing intervals. So our intervention included once every 10-year testing to once a year testing to 5 times per year testing. If there are no intervention, we expect about 30,000 HIV new infection will happen in this 40-year period in this province. But with this proposed intervention, the new infection will be reduced, and more frequent testing will lead to less new infections. Also, overall case reproduction rate, R0, will become 1 if testing is conducted more than once a year, leading to the elimination mode. And if we look at the new infection in 2050, actually, we expect 0 incidence. So for this kind of intervention, how much resources are needed? Left graph shows need for ART, shown by person years. Interestingly, quantity of ART required doesn't differ so much across different testing frequencies. This can be explained by the fact that one side, if we test more frequently, people need to start ART earlier. In that sense, we need more quantity of ART. At the same time, if we start treatment earlier, we can prevent transmission and thus new infection. So future needs for ART will be reduced. So this trade-off makes relatively constant need for ART across different frequencies. On the other hand, need for HIV testing is shown on the right graph. And as you see, if we test more frequently, amount of testing needed will increase. So if we convert this resource needs into US dollars and combine ART needs and testing needs into a cost, what happens? This graph shows cumulative cost of the 40 years. As you see, the cost does not differ so much, relatively constant, from the once 10-year testing to once a year testing. However, if we test too frequent, more than once a year, the cost will be nearly doubled, especially because of cost of testing. On the other hand, we look at the time course of the cost required, which is shown on the right graph. This blue curve shows once every 10-year testing. The cost will increase year after year. On the other hand, more frequent testing, for example, once every year testing shown in this red color, initial cost will be much higher. However, this cost will decrease later on, and especially beyond middle of 2020, it will save cost compared to less frequent testing. So cost effectiveness. The left graph shows cost per new infection averted. According to our calculation, testing once every 2 years to once a year was found to be most cost-effective approach. So far, I didn't mention about the impact of intervention on AIDS death, but with regard to the effectiveness and cost-effectiveness, we found a very similar pattern, like impact on new infection. As the next phase of our study, we looked into the impact if intervention is prioritized one single group. Testing frequency is set at once per year, but we target intervention only to one of these groups. This is the results. Upper left graph shows impact of intervention on new infections. And please note this amount is all the new infection in all the groups. But intervention is just targeted into one group. Comparing the targeting different population, prioritizing IDU population is most effective, followed by female sex worker population in reducing new infections. On the other hand, we assume low-risk women doesn't infect other groups except for children, so targeting low-risk women doesn't have any impact on new infection. Cumulative cost. Prioritizing IDU, MSM, female sex worker population have a relatively small cost because these groups have a relatively small population size. On the other hand, prioritizing male clients or low-risk women has a larger cost because of larger population size. Cost effectiveness at the bottom. According to our calculation, prioritizing IDU population followed by female sex worker population is found to be most cost effective in reducing new infections. On the other hand, prioritizing male clients or low-risk women has a much lower cost effectiveness even compared to the scenario we target all the groups. So let's summarize our findings. If we test more frequent, it is more effective in reducing new infection. However, if we test more frequent than once a year, costs will become much higher. However, testing once every 10 years to once a year, the cost will not differ so much. As a result, we found testing once every 2 years to once a year is found to be most cost effective. If we are to prioritize one single group, prioritizing IDU population followed by female sex workers is found to be most effective and cost effective. If I explain the same results using this diagram, in Vietnam, HIV prevalence is highest in this population with drug-injecting behaviors, and HIV is transmitted to other groups. So if we prioritize these groups, we can affect epidemic of all the groups. However, if we target the population in the downstream of the epidemic, we cannot impact people in the upstream of the epidemic. Limitation of our study includes that we used only a single province data, and we also have to revisit validity of assumptions. We didn't consider scale-up of other prevention interventions. But as a next step of our study, we are trying to address these limitations, but also we are trying to conduct sensitivity analysis. Nevertheless, despite these limitations, I believe our modeling study suggests early ART is likely to have a substantial impact on Vietnam's concentrated epidemic and should be considered as a critical element in the combination HIV prevention. Prioritizing key affected populations is likely to enhance cost effectiveness. An early ART in IDU population may also have a potential clinical benefits because this population has a high comorbidity with active tuberculosis and viral hepatitis. Success of early ART intervention will depend on how we can reach and help these people to know their HIV status. And therefore, it is essential to address access and retention barriers for key affected population, including stigma, discrimination, and punitive laws. Last but not least, synergy with other prevention intervention will be critical, since opioid substitution therapy, needle syringe program, and condom promotion all likely to have a high impact on new infections. I would like to acknowledge my co-authors, colleagues in Geneva and Vietnam. Thank you very much.